everybody, I'm Elisa. I'm back, and we're going to go through the respiratory system a little bit more. And this time we're going to take a stop at the trachea. So the trachea is your good old windpipe. It's, yeah, I'll just show you a picture. It's a little bit better. There we go. Okay, so you would imagine this part is where your lungs are. Up here is where your, mouth and your nose is up here. So this is the beginning of the lower part of your respiratory tract, right? And it's relatively rigid. It has this kind of neat like ring structure, right? These little cricoid cartilages. And so if you can see, they have kind of like a C shape. And then they have a tiny little muscle. So there's like some expansion, some contraction, little bit there. For the most part, it's supposed to be like a relatively kind of semi-flexible, semi-rigid structure, and it's facilitated by all these little tiny ligaments that you can kind of see down in here. Like these, they're so tiny, and we'll talk about those in a little bit. But what I wanted to do is just kind of give you an introduction to that structure. We already talked a bit about the larynx, so we're going to focus more on the lower part of the trachea. And the trachea is eventually going to divide into these. When it divides, it becomes the bronchi, right? So here's like trachea proper, right? So that's the trachea proper. And then over here is when we get into like bronchi town, right? And then the bronchi starts with two, and then it subdivides and it subdivides and it subdivides and all that good stuff. Okay. And kind of like roll back. Oop. Okay. Okay, so it's a relatively kind of rigid tube. Yeah, it's about a foot long or ish. It's only about 2.5 centimeters in diameter, which is about an inch, right? So it's anterior to your esophagus, so it means that it's in the front, right? So it's esophagus, right? Here's like a head of a nose, eyes, right? So esophagus is going to the back, and then the trachea is up front, and that's why your Adam's apple, which is also like located over there by the larynx tracheal conjunction. That's why that's up front. It has opening in the C rings that face posteriorly towards the esophagus. The opening is back here, the muscular opening, and that's going to be what kind of like allows a little bit of expansion and contraction. So the trachealis muscle, we'll take a look at that. Teeny, tiny, tiny muscle is opening your rings, and it helps us to adjust that airflow. The trachea is lined by ciliated pseudostratified columnar epithelium, and whenever you see this, think like goblet cells, basically, like just gobs of goblet cells making mucus and excreting or pushing it out into the surface. Okay. They are also ciliated, so they have sweeper tops, little sweepy sweep tops to move all that mucus along. What they call it the mucociliary, like mucus and then cilia escalator. So what it is, it's kind of like the idea is it's like pushing up and out this debris removal. It's really mainly just trying to get to the esophagus, so you can like, I guess, swallow it later, quite literally, so you can do that exactly thing. Because are going to inhale some particles. Like the respiratory system is not a super well evolved system. Like it is no digestive tract, ladies and gentlemen. So there's definitely going to be some issues, which we'll talk about a little bit more in pathophysiology. When we do that, the middle trach layer is going to be connective tissue beneath the tracheal epithelium itself. And it's going to have some lymphatic nodules. So trachea or the windpipe actually like kind of like swelling and closing up is a very real thing. It is very reactive. The adventitia is the outermost layer of the trachea itself. It is a connective tissue, and so it kind of like blends into some of the other connective tissues, right, of the mediastinum, which if you remember, it's like here's the heart, right, and here's like some lungs, right, and then there's this like serosa that covers that kind of middle part of the heart and lung area, if you remember properly. Okay. So also it's going to terminate or end at the right and the left bronchi. Um, so that's how it is. So it's like trachea is the straight pipe, and then when you start splitting it off, that's the bronchi. Right. So it's going to do that right at if you remember the sternum, here's the manubrium bone, and then the sternum way back, AP1, right? Right, it's going to branch off right about there. So, if you just, that would help you like just locate that on individual. Okay, here it is. In all its glory, everything we talked about, so the larynx and all that good stuff, but mainly here's the trachea, right here, going into the bronchi, down here below, and these are the conductive airway routes. Some flexibility, a lot of rigidity. Okay. Here is a shot of the epithelium. So it's like a close microscope shot. And so let me explain what's going on. Okay, so see this? This is the goblet cell tops, and that is like mucus being squished out into the top, right? Secreted out. And then these are the cilia, right? And so what these cilia are doing is they're taking any of these particles, that are stuck in the mucus, and they're sweeping them out away from the lungs. Because the thing about the lungs is, the digestive system we've been talking about is a really well evolved system because there is, mainly because of this, like there is an in and there is an out hole. Like that is some easy stuff. So that means like no matter what you pack in this side, you can actually just accelerate it and push it through and it'll leave. But the lungs are a little bit different. Like the lungs is just this one-way sack, really. And so when things get stuck in there, it becomes a problem. And so, if there was an exit, it probably would be less of a problem. But that's just kind of not how those swim bladders were designed. Okay, so some things pathophysiology look at. So the idea of the tracheotomy is to make a temporary opening in the trachea and insert a tube, such as a straw, to allow airflow. Um, a permanent opening is a tracheostomy. Okay. And so if somebody has upper airway obstruction, either due to collapse, inflammation, a handful of other things, it allows you to kind of intercede. So if here's like the trachea, here's the bronchi, and here is like crushing or inflammation due to like maybe a car accident or maybe due to some type of like an allergic response, you can make a hole there by inserting, a straw, and then that is how you would insert or allow air to kind of go in and then to go back out. Okay. So potential problems are going to be inhaled air bypasses the nasal cavity, so it doesn't get humidified, and so it's like really kind of shocking to the tissues. Also, it doesn't get as cleaned as well through the turbulence and through the rest of the mucous membranes. They become crusty, right? And they can become sites of infections. It's not super great. Um, and they don't allow if especially because they're here's if this is epiglottis is up here, they're not able to like kind of push out that collected mucus back into the esophagus, so it can just go through the digestive system. So it's just kind of not a good thing, bacteria and fungi and all that wise. The process is known as intubation, and the patient is on a ventilator typically, and air is introduced directly into the trachea. That air must be pre-treated with a filter and pre-humidified to prevent injury. All right, so we'll go with the lungs next time. But for now, I hope you enjoyed that little talk about the trachea, and I also hope you're having a wonderful day. All right, goodbye.